We have discussed in our last class about the somatoform disorders, and we have discussed a little bit about the personality disorders. So today we'll see in detail about the personality disorder. So hope you have gone through the study material, so it will be easy for you in understanding about the what is personality disorder. So let us see what we are going to discuss today. We'll discuss about the what is personality, then what is personality disorders, then cluster A personality disorder, cluster B and cluster C, and then in the last we will discuss in brief about socio-cultural causes of personality disorder. So what is personality? So it is a set of unique traits and behavior of an individual. We all know that's why we all are unique, and no one is, even twins are similar in look, but they are different in so many ways. These are typical traits, coping styles, and behaviors. They usually emerge during childhood and then become established pattern by early adulthood. By the age of 18 or 20, your personality is more or less fixed. The continuity, consistency, and stability of these traits and dispositions over time define personality development. So, what are the traits and dimensions of personality? So, we all know that earlier it was discussed like neuroticism, extroversion or introversion, agreeableness or antagonism, openness to experiences, and consensuousness. These we are not going to discuss in detail. This is just to brief you about the different traits and dimensions of personality. So, type-based classification of personality. So type A. So what are the traits seen in type A? It's like they have high motivation, more than required motivation. They lack patience, feel short of time, feel like always burdened with work, and they are more susceptible to problems like hypertension, cardiac diseases, and other problems. Whereas they are having more uh, cardiac issues than other type of personality. Whereas in type B, there are no such type A traits will be there. They are flexible, they are low in stress, and they have relaxed attitude. They are adaptable to change, and they lack back tendency to procrastinate, means they sometimes delay the work, and they have lots of patience. Whereas in type C, they are cooperative and assertive, suppress their negative emotions, show compliance to authority. Whereas type D, they are shy, they have self-doubt, dissatisfaction, avoidance, proneness to depression, tends to have negative emotions. So in type C, generally, cancer is seen. Let us see the personality disorders. So they are heterogeneous group of disorders. Like personality disorders, it doesn't mean just one disorder. So usually it is characterized by all personality disorders generally characterized by forming a stable positive sense of self and sustaining close and constructive relationship. So they have problem in forming a stable positive sense of self and maintaining the relationship. So let us see the common features described in DSM-5 for personality disorders. So significant impairment in self and interpersonal functioning. The person's enduring pattern of behavior must not be flexible and should be pervasive, stable, and longer in duration that deviates from the individual's cultural expectations. It should cause clinically significant stress or impairment in functioning in various areas of life. Such impairment should be manifested in at least two of the areas, for example, cognitions or affectivity or interpersonal functioning or impulse control. So the exhibited or maladaptive behavioral pattern developed over time color their perception totally, which further determine reactions to newer events and situations in the same light. They do not learn from the new experiences. This causes repetitions of maladaptive behavioral pattern over and over again. So let me make it clear that personality disorders means the pattern should be fixed and reflected in almost all the situation. It's not like in one or two situations the patient exhibits such symptoms. It will be seen in whatever the situation the patient is. Let us see the cluster-based classifications of PD. People are often diagnosed with more than one PD. So people think if someone is having just one type of personality disorder, for example, antisocial personality disorder, so the person may not have other type of personality disorder. This is not true. Okay, one person may have many type of personality disorder, or one personality disorder with traits of or symptoms of other personality disorders. So disorders in the same cluster tend to co-occur. We'll discuss about the cluster. Personality disorders first appeared in DSM-3 on axis 2. Axis 1 disorders are symptomatic of axis 2 disorders. For example, a person may have depression, which could be a result of dependent personality disorder. However, the cluster-based classification of personality disorders have been questioned for its validity. We are not going into detail into this. And due to various overlaps across categories and clusters, it was proposed to remove the cluster organizations from DSM-5, but it still pertains due to its ease in diagnosis. So it makes your task little easy to understand the personality disorder and to make the diagnosis. That's why we still follow cluster-based variant. So as we have discussed, there are three clusters. In cluster A, there are three types of personality disorders: paranoid personality disorder, schizoid personality disorders, and schizotypal personality disorder. Whereas in cluster B, histrionic personality disorder, narcissistic personality disorders, antisocial personality disorders, and borderline personality disorders. In cluster C, avoidant personality disorders, earlier it was called anxious avoidant personality disorders, then dependent personality disorders, and obsessive compulsive personality disorders. Earlier it was called anarchistic personality disorders. So what are the why all these personality disorders, though they are heterogeneous, why they are put into this category of personality disorder? Because they have something common in their symptoms. So let us see the cluster A. In cluster A, these basically it involves thinking and behavior which appears unusual, odd, and eccentric to other people. It may range from distrust to suspiciousness, and even social detachment is very commonly seen. Whereas in cluster B, it can involve tendency of the individual to be dramatic, erratic, unpredictable, and also emotional. In cluster C, basically involve tendencies to be anxious and fearful. So let us see what are the difficulties in diagnosing PD. Diagnostic criteria are neither sharply nor clearly defined. Some of the personality diagnoses are not very common in the community setting. People with personality disorder may not fit completely in any of the categorization or diagnosis. This is very commonly seen. And then people diagnosed with personality disorder at one point in time, when interviewed after 2 years, get qualified for another diagnosis. And the diagnosis made on the basis of a structured interview or self-reporting inventories have been found to be low on reliability and validity. So it's not a easy job to diagnose anyone the personality disorder. Lots of experience is required. So to address this, unified dimensional assessment are being available, like 5-factor model based on 5 basic personality traits, which we call OCEAN: openness to experience, C for consensusness, E for extroversion, and A for agreeableness, and for neuroticism. So this is related to pathological extremes in personality traits: negative affectivity, detachment, antagonism, disinhibition, psychoticism. So these are the basically issues which create problem in diagnosing PD. Coming to the cluster A personality disorders. So we have seen what are the three cluster A personality disorders: paranoid, schizoid, and schizotypal. So let us see first paranoid personality disorder. So the features are persistent, unjustified distrust. So distrust will be there. Usually get suspicious. They may interpret the event unrelated to them or remotely related to them as personal attack on them. So they take very everything personally. They are very sensitive to criticism. Interpersonal relationship are strained. They put the blame on other people, guilty even for their own mistake and failures. They are always on guard, means they remain guarded. They are not very open up to even with the friends. They are usually argumentative. They have argument for each and everything, but they are in touch with reality, and they may experience certain transient psychotic symptoms during the stress. So the core features for diagnosis as described in DSM: they suspects without sufficient basis, then preoccupied with unjustified doubts about the loyalty or trustworthiness of the partner or friends or others, reluctant to confide in others, and they do not believe on others, they do not develop faith on others, reads hidden demeaning or threatening meaning of if you are talking to your friend, or if he has some personality paranoid personality disorder traits. So basically you have, even though you have say something casually, but the person may interpret it very differently. So persistently bears grudges and perceives attack on his or her character or reputation. So it's very difficult for to maintain the relationship with person having personality disorders paranoid. So what are the causative factors seen in paranoid personality disorders? Genetic factors play a much role. Partial genetic transmission linking it to schizophrenia. So slightly more common amongst the relatives of the people with schizophrenia. May also occur through the heritability of high levels of neuroticisms or even antagonism. And the psychosocial factors like mistreatment and traumatic childhood, parental neglect, abuse, physical or sexual, and exposure to violence. So all these factors may lead to personality disorder. So what are the treatments available for paranoid personality disorders? So the core thing is like distrustful relationship with their therapist. So this is basically very difficult for the therapist to establish rapport, to or like to develop faith. So and then they're not likely to seek treatment due to their personality issues, because they are guarded, so they do not become very open, they do not share their experiences to the therapist. And basically CBT is widely used, so emphasis on changing the belief systems and thought pattern. So but it's like all personality disorders, they require long-term individual psychotherapy. Coming to the schizoid personality disorders. So let us see the characteristics of these personality disorders. So pervasive pattern of social detachment. They are not very attached to anyone except one or two, and even though they remain with other people, they do not feel attached, and others also may not feel emotional closeness with them. With an extremely restricted range of emotional expression, so they have lack of varieties of emotional expressions. do not express much emotions. They do not usually seek out for relationship on their own. Others try to establish relationship even though they do not allow others to maintain close relationship. They have lots of boundaries in their relationship. Most often, they are cold, aloof, and indifferent to people around them. So this makes them more lonely because they are cold. They are not very interested in others. So others also, after some time, they get indifferent to such people. Not interested in maintaining close relationship with others, neither romantic nor sexual. Some of them are homelessness. They consider themselves to be observers rather than participants in the world around them. Uh, Often classified as loners and introverts, low level of openness to feeling. So, according to the DSM-5, if you see the diagnostic features, the core features can be enlisted like neither desires nor enjoys close relationship. Even though you try to make a very close relationship, they do not enjoy it. Almost always choose solitary activities, so they prefer such activities where others are not involved. Has little in having sexual experiences with other person, and takes pleasure in few activities only. That also with lots of restrictions, and lacks a close friendship or confidence other than first degree relatives, appears indifferent to the praise or criticism of others. See, so this is the difference in paranoid personality disorders and schizoid personality disorders. Schizoid personality disorders, they are indifferent even though you are criticizing them. Whereas in paranoid personality disorders, even though you have not criticized so much, even though the sentence was negative, they may see it as severe criticism and they may argue with you. So in schizoid personality disorders, they show emotional coldness, detachment, or flattened affectivity. So means the affect will be generally flat. So you cannot make out by seeing their face that they are happy, sad, elated, cheerful. No, you cannot make out any emotion. So it is flat affect all. So let us see what are the causal factors of schizoid personality disorders. So, a disruption in sociability could be due to some sort of impairment in the affiliative systems, genetics. Then, childhood shyness may also act as a predispositional factors. Childhood abuse and neglect is often prevalent among the individuals with schizoid personality disorders, and parents of children with autism are likely to have this disorder. So, what are the treatments of schizoid personality disorders? Because they rarely come for treatment, they do not seek treatment, they do not think they are having any problems, so they rarely come for treatment unless it is a response to some crisis such as losing a job or some other extreme issues. Therapy usually starts with making them understand value in social relationship. So this is the most difficult task to make them understand that there is a value in social relationships. Social relationships are very important. It's very difficult to convey this message to them. May taught about empathy and understanding others. So and training in social skills development. So they lack social skills. So when you like when we see someone, we greet them, we smile. So they lack such skills, interpersonal skills. Coming to the another third type of cluster A personality disorders, which is schizotypal personality disorder. It is characterized by bizarreness. Bizarreness in terms of symptoms, the thinking, the behavior. So oddities in thinking, speech, and other behaviors. So you will find their thinking, speech, and behaviors are odd. Odd means they are not in relation with the social norms. Excessive introversion, social and interpersonal difficulties, perceptual and cognitive distortions. Perceptual distortions, what are the perceptual distortions? Hallucinations. They may have hallucinations, they may have thinking distortions, for example, delusions, but not well established delusions, just overvalued ideas, you can say. And perceptual distortions are also uh, a very fleeting type of, and everything whatever they perceive they distort it, they see it differently, they think differently, and they are suspicious, and but their contact with the reality is generally intact, but sometimes they may lose the reality contact. Transient psychotic symptoms under higher level of stress may be there. So, like the hallucination and delusion, which very fleetingly it may appear in there when they are under highly stressed. So, if we see the DSM-5, the core features are ideas of reference. Ideas of reference is basically the person thinks that all others are talking about him, and whatever they are discussing, they are referring the patient. So this is called ideas of reference. When these ideas of reference become very established, when patient believes that, firmly believes that, they are definitely they are talking, and no one can shake this belief, and the belief and the patient is acting out also on that belief, then it becomes delusion. So most of them are having ideas of reference. Old beliefs or magical thinking is very common in schizotypal PD. Then unusual perceptual experiences, including bodily illusions and odd thinking and speech, suspiciousness or paranoid ideation may be there, inappropriate or constricted affect. So in schizoid personality disorder, the affect is flat, where you may find flat effect as well as inappropriate. And sometimes the patient is talking about something bad, but you may see the smile on the face of the patient. So behavior or appearance that is odd, eccentric, or uh, not peculiar, and lack of close friends or confidants other than first degree. So they do not have friends. So in cluster A, most of them they do not uh, they lack social relationship. It is on a continuum with schizophrenia. Absence of certain symptoms such as hallucination and delusion, they are not persistent. Even though they come, they are fleetingly come, very briefly. They may believe in magical thinking or believe that they have magical powers like being a clairvoyant, and may report unusual perceptual experiences but do not have extreme perceptual distortions, and considered as an attenuated form of schizophrenia. So it's very difficult to differentiate between schizophrenia, schizotypal personality disorder, schizoid personality disorders, and paranoid personality disorders. So let us see the causes of schizotypal personality disorder. So genetic factors play a very important role in all cluster A personality disorders. So it is a part of the spectrum of liability for schizophrenia occurring in first degree relatives, and they are at high risk of developing schizophrenia and or schizophrenia spectrum disorder. Prevalence in general population is about 2 to 3%. So in our country, 2 or 3% is a huge amount. And the psychosocial factors like deficit in the ability to visually track a moving target, deficit in ability to sustain attention, deficit in working memory and language abnormalities, low family socioeconomic background, then early childhood violence and abuse, poverty and lack of education. So, what are the treatments available for schizotypal personality disorder? So, almost 30 to 50% of the people have comorbid depression. Use of antipsychotic medication, community treatment, and social skills training as a combination is very useful in this personality disorder. This approach either reduces symptoms or has delayed the onset of later schizophrenia. So there is a tendency to develop a schizophrenia in this schizotypal personality disorder. So the treatment is very much required to delay the process of development of schizophrenia. Let us see all the three cluster A personality disorders. So, if we talk about the psychotic-like symptoms, not delusion, hallucination as well, but psychotic-like symptoms. So, there are three cluster A personality disorders: paranoid, schizoid, and schizotypal. So, positive symptoms wise, like ideas of reference, magical thinking, it is there in paranoid personality disorders and schizotypal personality disorders. But this will not be there in schizoid personality disorders. And if we talk about the negative symptoms like poor rapport, social isolation, constricted affect, it will be seen in paranoid personality disorders and schizoid personality disorders, but it may not be seen in uh, schizotypal personality disorders. Okay, so we have discussed about the cluster A personality disorders. There are three cluster A personality disorders: paranoid personality disorders, schizoid personality disorders, and schizotypal personality disorders. Coming to cluster B personality disorders. So let us see the histrionic personality disorders first. So it is characterized by exaggerated expression of emotion, excessive attention-seeking behavior. Their appearance and behavior are usually found to be very dramatic, theatrical, and at times sexually provocative as well. They also tend to be vain, uncomfortable, and self-centered when not in limelight. So they are very much concerned about their looks. Speech is often very vague, lacking details, and also impersonating, impersonistic, with a major concern of approval from others and tendency to view situations in an absolutistic manner. Prevalence is again about 2 to 3%, more prevalent in women due to maladaptive variants of female-related traits, mainly such as seductiveness, vanity, over-dramatization, and too much concern with one's physical appearance. So the core features of diagnosis are uncomfortable in situation in which he or she is not in the center of attention. So histrionic personality disorder people, they always want to remain in the center of attention. The when they are not found themselves in center of attention, they feel uncomfortable. Interaction with others is often characterized by inappropriate, sexually seductive or provocative behavior, displays rapidly shifting and shallow expression of emotion. Consistently use shallow expression of emotion means they do not feel in depth and their emotions are just superficial, and consistently uses physical appearance to draw attention to self. So they use hand movements will be more like they are arranging their hairs or clothes as a style of speech that is excessively impressionistic and lacking in detail, and shows self-dramatization, theatricality, and exaggerated expression of emotions. So the emotions are exaggerated but superficial. Let, let us see the causes for histrionic personality disorders. So, genetic link with antisocial personality disorder is found. Psychosocial factors like extreme versions of two common personality traits, extraversion, found to be high on gregariousness, means they want to remain with the people, openness to fantasies and excitement seeking. And another one is neuroticism. It's involved in the depression and self-conscious aspects. Maladaptive schemas, especially about the need for attention and to validate their self-worth, might also be responsible for these disorders. So let us see the treatment. So main attention on attention-seeking behavior. So the counselors or therapist main job is to modify the attention-seeking behavior. Major part of the therapy involves focusing on interpersonal relationships and taught more appropriate and acceptable ways to negotiate in order to get their demands fulfilled. Coming to the another personality disorders, which is called narcissistic personality disorder. So basically, it is an exaggerated sense of self-importance that the individual gives to oneself. Preoccupation with seeking attention, admiration, and lack of empathy. Inability to take other person's perspective. They may turn out to be rude in case of unsatisfied demands and higher prevalence in men. So, if such traits are there, it will be very difficult for others to maintain the relationship with such persons. So there are two types of narcissistic personality disorders. One is grandiose type. In grandiose type, the symptoms would be aggression, dominance, and grandiosity, known to be overestimate their abilities and underestimate that of the others. The same ability they overestimate theirs, but for others they underestimate. They provide self-references in each and everything. Okay, I have done this. I was like this. I am like this. I do this. I do that. They put themselves in each and everything, and they easily take offense and rarely forgive others. And close relatives and family who are more distressed about their behavior. So, if suppose the boss who is having narcissistic personality traits, it will be very painful for the subordinates. Another type of narcissistic personality disorder is vulnerable type. So, here the fragile sense of self-esteem, arrogance, and disdain to mask their shame, hypersensitivity towards criticism, usually avoid relationships and intimacy, usually have a high level of negative affectivity. So mood will be basically negative. So both types of narcissistic personality disorders are associated with high level of antagonism or low agreeableness, low modesty, arrogance, superiority, feeling of grandiosity, low altruism. They are not very helpful. They do not uh, give help to provide help to others, and tough mindedness. So if we see the DSM-5 criteria for narcissistic personality disorders, the grandiose sense of self-importance, preoccupation with fantasies of unlimited success, power, brilliance, beauty, or ideal love, and believes that he or she is special and unique, requires excessive admiration, has a sense of entitlement, and interpersonally exploitative. So they exploit the relationship. They lack empathy and often envious of others or believes that others are envious of him or her, shows arrogant behavior and attitudes. So the causal factors are grandiose narcissism is not generally associated with childhood abuse, neglect, or poor parenting, but perhaps with parental over-evaluation. So generally parents over give them overvalue. Vulnerable narcissism is associated with emotions, physical and perhaps sexual abuse, and intrusive controlling or cold parenting style. Increasing prevalence of narcissism is a consequence of large-scale social change with emphasis on characteristics like individualism, competitiveness, hedonism, and ambition, which we have seen in Western countries. Now it is there in our countries also. So we are giving lots of mm, eh, emphasis on privacy, individualism, competitiveness, hedonism. So, how to treat narcissistic personality disorder? So, the main focus of the therapy is grandiosity. Attention is also paid to hypersensitivity to evaluation and lack of empathy for others. Relaxation techniques are also useful because they get very easily agitated. So another cluster B personality disorder is antisocial personality disorder, ASPD. So they are regarded as social predators who charm, manipulate, and ruthlessly plow their way through life, leaving a broad trail of broken hearts, shattered expectations, and empty wallets. So, a tendency to persistently disregard and violate social norms and rights of others, so they do not feel remorse at all. Deceit, aggression, and antisocial behavior. They lack ethical or moral development, no remorse or loyalty towards anyone, impulsive, deceitful, and irresponsible, and they lie and cheat others. Almost 60% of them are substance abusers. So there are two dimensions of psychopathy, affective and interpersonal core. So lack of remorse, carelessness, glibness, lack of empathy, charm, etc. Whereas behavioral dimension, impulsivity, socially deviant lifestyle, poor and irresponsible behavior, parasitic lifestyle, etc. And so they do not have any type of guilt or remorse. Let us see the core features of diagnosis for ASPD according to DSM-5. So, inadequate conscience development can understand ethical value only at a verbal level. They can talk about ethics, but they cannot understand. Conscience development is stunted. Affective and interpersonal dimension is positively related to verbal intelligence, whereas antisocial dimension is negatively related to intelligence. May act out tensions and then worry them. Irresponsibility and impulsive behavior, total disregard for needs, regards, and well being of others, including very close friends or family members, high on thrill seeking, that's why they go for addiction, deviant and unconventional behavior. Rarely forego immediate pleasure for some future gain. So they actually guided by the immediate pleasure. Occurrence of alcohol or any other substance dependence and abuse, elevated rates of suicide attempts. So whenever they get a little bit insight about their behavior, the suicide is very common. So basically, the feature is like they say that uh, why we should follow the social norm what society has given us. So, rejection of authority, say do not follow social norms and rules. Difficulty with educational and law enforcement authorities, behave as if immune to the consequences of their action. Ability to impress and exploit others, very charming, win friends very easily. They do not find any difficulty in establishing relationship, but it's very very hard for them to maintain their relationship. They do not think for maintaining relationship. Sense of humor and optimistic outlook. Frequent liar, may seem sorry when caught in an act but are not so. They can say sorry but they do not feel sorry. good insight into other people's needs and weaknesses. That's why they exploit them. Find excuses readily for their conduct, usually projecting blame on others. Inability to maintain good relationship, ability to win liking of others initially, but rarely keep close friends and relationships. Irresponsible, cynical, unsympathetic, egocentric, ungrateful, and remorseless. Cannot understand love, but they show lots of love and affection, but they do not understand at all. That's why they break very easily the relationship. Violence towards family members is common, and with partner also. Manipulative and exploitative in their sexual relationships, and considered as a menace for family and society. So let us see the causes. Genetic influences. Adopted children of criminal mothers had significantly higher rates of conviction. Children of criminal mothers who had spent more time in the orphanages later became criminals. Interaction between genetics and environment is seen. And likelihood of antisocial personality disorder increase in case of childhood history of conduct disorder and ADHD, attention deficit and hyperactivity disorder, ADHD. So under arousal hypothesis is there where abnormally a low level of cortical arousal. This could be the primary cause of risk-taking and antisocial behavior. Lower skin conductance and the heart rate during rest periods and slow brain. Fearlessness hypothesis. Psychopaths have a higher threshold for experiencing fear than most of the other people. Three major brain systems and their functioning malfunctioning influence learning and emotional behavior of psychopaths. So behavioral inhibition system located in the septohippocampal system, involving both serotonergic and noradrenergic neurotransmitter systems, plays a role in our ability to stop or slow down in the wake of impending punishment or novel situations. So first one is behavioral inhibition system, another one, second one is reward system, and third one is fight and flight system. So they are capable of manipulating their therapists. So if you provide treatment, it will be very difficult for the therapist because they manipulate them also. There are very few documented successful treatment cases of ASPD. Mostly therapists agree with detaining or imprisoning them for their antisocial acts so that any future such acts can be avoided. Parents are trained to identify these behavioral problems and using a reward-based system to encourage pro-social behavior. Family dysfunction, poor socioeconomic status, or even high conduct-related issues are responsible for poor therapeutic outcomes. CBT mainly targets social perspectives, helping them in increasing self-control, increasing victim awareness, like to develop a sense that how others can feel, teaching anger management skills, changing antisocial attitudes, and reducing or treating substance use. Coming to the fourth cluster B personality disorder, it is borderline personality disorder. The term was originally for condition being between neurotic and psychotic, so that's why it was called borderline. The characteristics pattern of BPD, impulsivity and instability in self-image, moods, and relationships. So they can go through rapid shifts in emotions from one to another. Short periods of psychotic-like symptoms such as losing contact with reality, delusional experiences, or even hallucinations. A significant impact on social, occupational, and academic functioning, comorbid with mood disorders, personality disorders, eating disorders, and substance use as well. Comorbid means this borderline personality disorder can be present in mood disorders, anxiety disorders, eating disorders, and addiction. Behavioral and affective symptoms. So their sense of self has been described as fragmented. They have highly unstable relationship due to their unstable self-image and affective instability. Their fear of abandonment is also very strong, and thus they try to avoid it as much as possible. So they show clinging and dependent behavior also, over possessiveness, you can say. They are prone to get into self-destructive and erratic behavior, deliberate self-harm. Suicide attempts are also very common. Self-injury or self-mutilation is a common feature of BPD. According to the DSM-5, the core symptoms of diagnosis to diagnose BPD, like frantic efforts to avoid real or imagined abandonment, a pattern of unstable or intense interpersonal relationships, identity disturbance, markedly and persistently unstable self-image or sense of self, impulsivity in at least two areas that are potentially self-damaging, recurrent suicidal behavior, gestures or threats, or self-mutilating behavior, affecting affective instability due to a marked reactivity of mood, chronic feeling of emptiness, inappropriate intense anger or difficulty controlling anger, transient stress-related paranoid ideation or severe dissociative symptoms. Let us see what are the causes of BPD. So genetic predispositions, strong influence of genetic factors, both affective instability and impulsivity are partially heritable. Genes involved in regulation of dopamine and lower serotonin levels. The low serotonin level may lead to impulsive behaviors, and structural brain abnormalities like reduced volume of hippocampus and amygdala. And psychosocial causative factors are childhood trauma, adversity, and maltreatment. In most of the cases of borderline personality disorder, they report childhood trauma and maltreatment. Diathesis stress model or theory, presence of stressors like trauma, parent, parental neglect, failure, or some kind of loss, weak, weakening of family structure. Higher, so let us see the treatment, how to treat. Higher proportions seek for treatment. Yes, so this is that borderline personality disorder patients, they seek treatment, they come for treatment. Anticonvulsant and antipsychotics are usually found to be effective to control their mood and impulsive behavior. Drug abuse or suicide attempts may reduce the efficacy of treatment. Dialectical behavior therapy (DBT) given by Marsha Linehan et al. In 2006. So the core feature of this therapy is priority to suicidal behavior, then the ones that interferes with the therapy, followed by the behaviors which may interfere with the quality of life, then taught to regulate their emotions and handling problems on an everyday basis, then they are made to trust their own responses. Okay, so in cluster B, we have seen histrionic personality disorders, uh, antisocial personality disorders, narcissistic personality disorders, and borderline personality disorders. Now we see cluster C, personality disorders. So avoidant personality disorders. So extreme social inhibition and introversion is seen in avoidant personality disorders. They have a pattern of limited social relationship and are reluctant in social interactions, and they want, but they are reluctant due to their personality traits. They do not seek out for other people as they are scared of being criticized for rebuffed by them. And so, if they think the person can accept them, then only they approach the person. There may be a desire for affection, but they often feel lonely and bored. So let us see the difference between schizoid personality disorders and avoidant PD. So individuals who are asocial because of apathetic, have flat affect, indifferent towards criticism, not interested in interpersonal relationship, they enjoy their aloofness. So this is schizoid traits of schizoid personality disorder, not the avoidant PD. Whereas individuals who are asocial because of avoidant personality disorder, they fear rejection. Thus, they are interpersonally anxious. It fits the diagnosis of avoidant personality disorders. They do not enjoy their aloofness. They are not able to relate themselves to others. Low self-esteem might be associated to depression, generalized shyness or nervousness, and may also avoid novel situations and even emotions. Inability in experiencing pleasure and could be simply a more severe manifestation of generalized social phobia. If we see the DSM-5, the core features for diagnosis of APD, avoidant personality disorder, is avoids occupational activities that involve significant interpersonal contact, unwilling to get un- in invo- unwilling to get involved with people unless certain of being liked, shows restraint within intimate relationship, preoccupied with being criticized or rejected in social situations, inhibited in new interpersonal situations, and views self as socially inept, personally unappealing, or inferior to others, unusually reluctant to take personal risk or to engage in any new activities. Let us see the causes. May have causal roots in innate inhibited temperament. Uh, so the root is repeated here wrongly. Genetic vulnerability can also be seen in people with social phobia. Fear of rejection and negative evaluation has also been found to be moderately heritable, and these biologically based inhibited temperaments may actually serve as a diathesis and may lead to the development of avoidant personality disorder in presence of some stressors like emotional abuse or rejection as a childhood. So, what are the treatments? Problems experienced are similar to social phobias. Treatment is also similar to social phobia. You have to teach them behavioral skills, behavioral intervention for social skills, assertiveness, anxiety alleviation, and therapeutic alliance is an important predictor in avoidant personality disorders, because if you discussing with the patient may also feel anxious, so the patient may avoid. So this is the therapist's job to maintain the alliance. Another personality disorder is dependent personality disorder. We have seen avoidant personality disorder, now dependent personality disorder. So it is characterized by an individual's extreme need to be taken care of, thus pointing towards his submissive and also clingy behavior. They may show fear of being separated from others. They may not get angry with others or find fault in others due to their fear of being separated from others or losing their support. They may remain in physically or psychologically abusive relationships due to their dependence. They give lesser importance to their own needs. This disorder is associated with prevalence of neuroticism and agreeableness. More prevalent, it's again wrong, more prevalent in women due to higher prevalence of traits such as neuroticism and agreeableness in women. Some features also overlap with that of histrionic, borderline, and avoidant personality. Like both borderline and dependent personalities fear abandonment by people around them, but their reactions to it can be different. For instance, people with borderline personality may react with feeling of emptiness and rage, whereas people with dependent personality may initially become submissive and then may seek for new relationship. So, according to DSM-5, the core features of dependent personality disorders are, and this patient, like they have difficulty making everyday decisions without an excessive amount of advice and reassurance from others. They need they are in need of others to assume responsibility for most major areas of his or her life. Difficulty expressing disagreement with others because of fear of loss of support or approval. Difficulty initiating projects or doing things on his or her own due to lack of self-confidence, and goes to excessive lengths to obtain nurturance and support from others, feels uncomfortable or helpless when alone, urgently seeks another relationship as a source of care and support when a close relationship ends, is unrealistically preoccupied with fear of being left to take care of himself or herself. So the causes are genetic influence have been found to be modest. Traits such as neuroticism and agreeableness are influenced by genes. At least partial predisposition to dependence and anxiousness reinforce their behavior. This may make them prone to negative impact of authoritarian and overprotective parenting. The underlying schemas about themselves might be maladaptive and thus may have a core belief about them being weak, incompetent, and requiring others. They show 100% compliance to the therapeutic regime if we provide any treatment. So they look like ideal patients and eagerness to share their problems but become submissive in general. So they believe that they think that this is the therapist's responsibility to do everything for the patient due to their dependent personality disorder. So they want to become dependent on the therapist also. Their submissiveness becomes a major hindrance in the therapy. Their core beliefs about being weak and dependent on others is challenged. CBT has proved to be a useful tool. Coming to the third personality disorder called OCPD. So presence of excessive concern with maintaining order and control, and perfectionist tendencies including higher attention to rules, order, and schedules. And so they are very high in perfectionism to the extent of dysfunction. An underlying quest for perfection in everything, poor time management, may have difficulty in doing anything for leisure and entertainment due to devotion to work, and may be regarded as rigid or cold. So there is a difference between OCD and the OCPD. In OCD, the obsessions and ritualistic compulsions are there, whereas in OCPD, obsessions may not be there and rituals are may not be very much, except for ordering or perfection. So what are the core features? A pervasive pattern of preoccupation with orderliness, perfectionism, and mental and interpersonal control. Preoccupation with details, rules, lists, order, organization, and schedules to extent that the major point of the activity is lost. Shows perfectionism that interferes with task completion, is excessively devoted to work and productivity. Overconscientiousness may be there. So reluctance to delegate tasks or to work with others shows rigidity and stubbornness. So causative factors are basically biological factors, and social factors. And certain personality traits are also like high on consensusness seen in OCPD. If we see the treatment, the therapy usually focuses on their need for keeping everything in control and order. They are taught relaxation and distraction techniques to keep the compulsive thoughts away. CBT has been found to be effective. So the last slide, the sociocultural causes of PD. So there are lots of socio-cultural causes of various PDs we have seen and we have discussed. So as emotional dysregulation and impulsive behavior has increased over the years, it may have some association with the increased prevalence of borderline and ASPDs over a period of time for the same time frame. It may have its connections with breakdown of traditional family systems and various other social structures. Thank you.